Health, broad responsibilities across the county, the management of clinical policies and standards for assessing the need for involuntary mental health treatment in a variety of settings: hospital, emergency rooms, inpatient units, and the outpatient system. In this capacity, Dr. Shaner works with many organizations to help ensure that individuals with mental health crises receive care that recognizes both the critical need to preserve their autonomy and the obligation to give them safety and support. So we're going to hear from him first about supported decision making. I'm going to try to keep these talks to about 10 minutes to give us some time at the end to take questions again. So Dr. Shaner.
Great, well, thank you, Ben, and thanks for inviting me here to this really important conversation. It's an honor to be here as both a clinician and a bureaucrat. So, as a clinician, I'm going to present a case, and as a bureaucrat, I'll go on endlessly about its policy implications. Not really, but now this is going to be a difficult case. It's a case because, as Dr. Sachs, I think, noted earlier, stigma is best conquered by human faces. So this is a case, but as I said, it's a difficult one, but it's cases like this that are likely to drive policy that will apply to all people. So 3 Tuesdays ago, Tuesday is important because that's when the Board of Supervisors meet in every county across the country. So 3 Tuesdays ago, the LA County Board of Supervisors passed a new motion that directs our county council to work with the Department of Mental Health to re-examine all state mental health laws for purposes of finding more effective ways to help homeless individuals with severe mental illness get treatment and suggest possible amendments to these laws. And they gave us 45 days. So, gotta leave right away. We might ask for an extension. A lot of these laws people are talking about directly determine what clinicians do. Clinicians at the front lines know the necessity of autonomy in forwarding true recovery and quality of life. And yet, the machinery of our system currently neither reliably supports autonomy nor provides an effective alternative. So I'll focus on some of the challenges that clinicians face in participation in supported decision making for people with serious mental illness who might meet state definitions for involuntary care. Before I was a bureaucrat, I spent 20 years in the psychiatric emergency service at USC, so I know firsthand the terrible problems and extraordinary potential of people with severe mental illness. Later, as medical director for LA County, I play another role. In California, oddly, the state delegates many functions regarding involuntary care to the county mental health agency, and the management of a number of these functions is within Office of Medical Director. When people are in critical situations, they often call my office directly or get referred there, and sometimes our office can help with facilitating good outcomes, and regardless, we certainly have day-to-day exposure to systems issues pertinent to supported decision-making. So here's a case. A few details are changed, but it's pretty accurate. There are many other cases like this. But in this case, this is Mr. A.B., 35-year-old male with a 15-year history of literally scores of involuntary psychiatric hospitalizations engendered by disorganized and dangerous behavior, episodes of confusion, disorientation, occasional paranoid delusions, sometimes doing things like breaking into personal residences to take food or go to sleep, taunting gangs of youths with racial remarks in dangerous parts of town, living for extended periods on the street, eating scraps, wandering in traffic. Often there's medical hospitalizations due to physical assault or malnutrition or liver damage. He has periods of heavy alcohol abuse and possibly other substances. He's been diagnosed with the usual plethora of psychiatric terms, everything from brain damage, they're not mutually exclusive, brain damage from childhood seizures, bipolar disorder with psychotic features, alcohol use disorder. There's no treatment that has been clearly effective in ameliorating his behaviors, including a broad range of medications and psychotherapy. However, his compliance with all forms of treatment has been minimal. But here's another issue. Despite this history and what you might think, when stabilized, Mr. A.B. presents as an articulate, thoughtful, and intelligent person who desperately wants to maintain his dignity and his autonomy. He freely admits to saying anything necessary to be released from involuntary detention in psychiatric units, and he understands his legal rights well. Further, he has a mother who has stuck by him throughout his life. Even today, spends the bulk of her time advocating for her son to get treatment, calling emergency services for responses, driving the streets looking for him, pleading with courts to grant LPS conservatorship over her son. Now, the usual course of events, and there are many cycles all the time, is as follows. Law enforcement or psychiatric mobile response teams, often after calls from family, respond and find probable cause to detain as danger to self, others, or gravely disabled. He ends up in an emergency room. There's 70 emergency rooms in LA, and then ultimately into a locked psychiatric unit, of which there's some 25. Within a couple of days, he appears lucid and coherent after some stabilization, and he pleads to leave, often noting that a life of incarceration is no life at all. Family, past treatment providers, and the patient often confer with current hospital staff to attempt sorting out the best course. Most of the time, he's discharged fairly quickly by hospital staff or via court proceedings because while nobody thinks he's fine, they do not believe that there is immediate grounds for further involuntary detention. This cycle repeats itself every few weeks. But about 15% of the time, he's held for a longer period. This is always on the basis of considering not only what he might look like at the present, but on clinical history, which to some suggests grave disability. Petitions for LPS conservatorship are sometimes filed. They're usually dismissed after court appearance, where he looks very well and speaks movingly. Very occasionally, the court finds for conservatorship and has granted guardianship under conservatorship to the mother. When conservatorship is granted, Mr. A.B. suffers through confinement, and I mean that literally, often writing moving poems and letters to his family, to others. His last lengthy hospitalization, several months, was at a state hospital, where staff, after some time, voiced the belief that they were not providing meaningful care beyond confinement that provided safety from streets, drugs, and possible harm. As has happened before, the mother was moved by her son's distress and promises to abide by treatment in mental health or substance abuse rehab facilities. She approved discharge to a rehab facility, and within hours, the patient was back on the streets. And literally as of last night, the mother was calling desperately to police and to DMH after hours for help in getting her son care.
So, Dr. Shaner, that's someone who's does have the capacity to make some decisions that they're often bad ones, right? So that makes that a very difficult case in terms of decision making, right?
And yet can articulately say, these may be bad decisions to you, but I think it would be a bad decision to spend my next 35 years locked up.
Yeah.
It's a tough thing. So what are the challenges to clinicians in a case like that? So just a couple, maybe three. Actually, I didn't mean that to be funny. There probably are a lot more challenges we could all think of. But first, our current laws insert an overwhelming overlay of regulatory processes governing relationships between an individual and clinicians. Being a mental health clinician legally requires someone to follow many procedures based not solely on clinical judgment or conviction, but by regulation. Decisions about what sort of consent may be valid, what third parties may speak about in regard to someone under care, and what elements must be included in treatment plans must all conform to various legal codes and standards. The cycle that Mr. A.B. experiences occurs as law enforcement, or first responders, clinicians, administrators, and courts all assiduously comply with regulatory processes. Here's another challenge for clinicians participating in supported decision-making. Legal liability for adverse outcomes arising from clinicians' decisions rests heavily and personally on clinicians. The consequences of personal autonomy in all of us, as Mr. Martinez noted earlier this morning, can be both exhilarating and grave. But to the extent that adverse consequences of that exercise are made the responsibility of another party, that other party will be more hesitant to encourage decisions that might have danger. In this case, with Mr. A.B., many a clinician has thought that better to discharge Mr. A.B. AMA, that's against medical advice, after determination that legal grounds to detain do not exist, than to risk consequences to licensure and sometimes pocketbook of supporting autonomy. And finally, at least for good clinicians, concern extends to preserving supportive networks for our patients. We recognize that a family's need for support and assurance of safety for their loved one is important to preserve that. As with Mr. A.B., when a clinician helps a desperate family by referring for investigation for LPS conservatorship, it requires soul searching. And whatever the ultimate choice, it can rupture bonds of trust among patients, families, and clinicians. So none of this is to say that supported decision-making shouldn't become a standard of practice, or that we cannot get there. We must get there. This case is simply to suggest that, among other things, we should deal with the associated clinician challenges that create perverse incentives for unilateral decision-making, at least in situations other than street psychiatry.
Well, we'll revisit him. I think that is the kind of case where it's a particularly thorny one, how it is applied in that particular case, where the person is repeatedly making decisions against their best interests in landing in lockup. If you don't mind, let's move on. We have a little bit more territory to cover. We'll come back and ask, I think, specifically about Mr. A.B. I'd like to hear. I want to introduce this